Hello, my name is Carolina Ramos, and I'm doing my presentation on what interventions can be applied to reduce the risk of patient harm resulting from falls. For my PO question for patient population, it's going to be patient falls in the hospital that can cause injury or harm to the patient. For E, exposure, new setting in a hospital, and debilitating medical problems that can increase fall risks. And for outcomes, it's what factors contribute to a high fall risk during patient hospitalizations. Relevance of my PO question is that falls hurt patient outcomes. If a patient falls, it's usually going to add more days to their hospitalization. An average amount is 6.3 days. Falls can lead to serious injury or death, such as fractures, traumatic brain injuries, and of course death. Falls are considered preventable under Medicare and Medicaid regulations. Obviously, a lot of things happen in a nurse's shift, so it's not always preventable as they state, but according to them, it is preventable, and due to that, it does cost the hospital a lot of money because if a patient falls, that is completely non-reimbursable, and the hospital has to eat the cost at 100%, and it costs an average $14,000 on a person's medical bill if they do fall with scans and tests and labs. It states here that $34 billion it costs the U.S. government a year due to patient falls in the hospital. Approximately a million people fall in the hospital a year, and 30 to 35% of these falls result in an injury. For my literature research, I chose 3 different databases: the SINAHL Complete, National Library of Medicine, Health and Medicine Gale 1 file. For my keywords were nursing, falls, injury, acute injury, fall prevention, and my articles chosen were within a 5-year span of 2021. Most were full text, English, and peer-reviewed. So those 3 that I chose all have that included, and as you see, I found different articles. For my articles, I chose 3 different articles. The first, Hospital Falls Prevention with Patient Education, a scoping review. For the method, 2 professional reviewers determined the quality of the different articles studied and conjoined the best educational fall prevention methods. And the results showed that not one single method was above another. The best way to prevent falls, according to these researchers, were a conjoined different type of methods such as face-to-face, discussions, pamphlets, booklets, videos, and so on. My second article was Video Monitoring for Fall Prevention in the Hospital, Current Evidence and Considerations. Here, 10 different cameras were installed in an ICU room with 5 mobile cameras used to monitor, and it showed that a total of 1,000 falls were prevented from 1,067 potential falls. A third article is Falls with Injury in Hospitalized Adults, Solving the Problem with an EHR Scored Fall Risk Tool. EHR means Electronic Health Record. Here, 8 med-surg units in a large hospital were reviewed over an 8-week span, and the electronic health record determined what a patient's fall risk score would be instead of the nurse's judgment using just the normal tools that they have. And the results showed that it did decrease the number of falls. Pre-intervention was 0.47. Post-intervention after using the electronic health record was 0.31, so there was a decrease of 0.16. For study number 1, Hospital Falls Prevention with Patient Education, a scoping review. So the title doesn't state if nurses are involved. The purpose of the study is obviously Hospital Falls Prevention with Patient Education, as the title states. Tables were used to organize their data with each article that included and did not include, as well as their fall outcome. The variable was X variable being the facility and hospital policy and procedures, and Y variable being the number of falls. This research design was systemic review qualitative, and human protection was not discussed. The two independent reviewers did find over 9,340 citations, and they reduced their articles only to review 43. A separate person was used just to make sure that the articles they used were free of discrepancies, and then they made charts and put in the different type of methods used in each article. The data they collected was from 6 different countries, mostly in the US. The articles were used, 22 of the 43 articles were from the US, and some were in long-term health care facilities, but most were in the hospitals. So the result of the study showed that interventions that include patient education do have the potential to reduce falls. Not one method was more effective than another. Usually a combination of methods was used, face-to-face discussions, handouts, and videotapes. Limitations obviously was that out of over 3,000 articles they could have chosen, they only chose 43, so it definitely decreased the amount of articles that they could have used. And nursing implications is that the nurse is the person that's giving most of this patient education. Physical therapists might discuss, but it's mostly up to the nurses, and physicians don't usually discuss this with the patient as they are limited time. For study number 2, I have video monitoring for fall prevention in the hospital, current evidence and considerations. As this title states, video monitoring is being used for fall preventions in the hospital setting. It did not state if this was nurse-driven strategies that were implemented or evaluated. The purpose of the study is to evaluate if evidence exists for the effectiveness of continued video monitoring at preventing falls. There was a research of literature done from different databases, and they use different key terms such as video monitoring, video surveillance. So the variables of study were X variable and dependent variable as the video monitoring, and the Y variable, the dependent variable, being the number of falls. Research designed, it was a mixed method, quantitative and qualitative. Human protection was not addressed. The study discussed how different databases here regarding video monitoring was effective in nursing units were conducted, and then based on the positive reviews, hospital administration decided to use video monitoring in different intensive care units or step-down units. It did show that there was a reduction in falls overall from one of the units, with a total of 1,000 falls being prevented from 1,067. The other article showed a decrease in falls with no mathematical data presented. So in comparison, it does show that using video monitoring does significantly reduce falls as when compared to sitters. Also, the administration was happy due to it cutting their costs, not having to pay a sitter for each different patient, and instead only having to pay one person to monitor the cameras, and that costs way less than different people having to pay them hourly. The limitations of this article was that only 6 articles were used, and not all of them provided mathematical data or any type of statistics. And also, these video monitoring methods were only used in ICU and step-down units, so it would be more effective to use in busy units such as med-surg, where things are very fast-paced and where the majority of the falls actually happen. Nursing implications is that a nurse could be the monitor tech, but most likely they will use a PCT, patient care tech, and have the nurse involved, giving higher levels of care. For study number 3, I have falls with injury in hospitalized adults, solving the problem with an EHR scored fall risk tool, EHR being the electronic health record. As the title says, it's to solve the problem of falls causing injuries in hospitalized patients. The study states that due to possible nurse error when completing the fall risk tool, some interventions aren't done or they're overlooked, so implementing an electronic health record tool can accurately identify fall risk patients and prevent falls and injuries. The literature here, the literature review was found under problem description and population sections, and statistical information concerning falls in the adult medical surgical units leading to injuries, as well as age percentages, were used as a reference. For my X variable, I have the EHR fall risk tool, and my Y variable being the number of falls. This research design is quantitative, and human protection was not addressed in the study. All of this data came from a Magnet level 1 hospital in New Jersey. It was done pre-COVID, pre-pandemic. It was supposed to be a total of 8-week study, 5 weeks pre by the nurses doing the fall risk assessment, and then 5 weeks post. So in the time frame, the nurses used their original fall risk tool to determine what the patient would fall under, and then 5 weeks later it would be the EHR using the tool. So the test actually found the results of the intervention that pre-intervention the results were 0.47 for falls. Post-intervention was 0.31, so there was a reduction of 0.16, showing that using the electronic health record was actually more effective than a nurse's judgment. The limitations of the study was that due to the study being conducted into March 2020, which is right when the pandemic started, the study did have to be cut short. Due to this, they could not complete the post intervention for the 5 weeks that they originally wanted, so the study had to be cut down to 8 weeks instead of 10 weeks. Regardless, it did show that during those 3 weeks of post intervention, using the EHR was effective. And then nursing implications, obviously this directly affects the nurses. Nurses are the first line of contact in the hospital in determining a patient's fall risk, so having a program that determines that for you does take away from nursing responsibility. However, the nurse still has to know what score the patient has, even if it is the EHR that does this, and the score does change depending on what a person's level lab work, diagnostic tests, all that determines what their electronic healthcare record will determine what their level is. So a nurse still has to be cognizant and look and see what the fall risk potential is for that patient, even though they don't do it personally. So conclusion, the aggregate collective data from these studies suggests that different interventions can reduce patient harm or injuries resulting from falls, whether it be multifocal video monitoring or use of computer programming. Numerous concomitant interventions can reduce the risk of falls, thus reducing fall-related injuries that kill thousands of Americans daily. And here I have 7 ways to prevent falls. Always call for assistance. Use assistance devices such as walkers, canes. Make sure that the area is well lit, clear of clutter. Try to keep frequently used items nearby. Take medications on time, and try to use non-slip shoes. Thank you. There's my references.